Thanks again. It's live from El Paso, Texas, and Indiana University. I'd like to welcome Brian Nickel. This is Brian Davis. I am coming to you from SAGES and the Residency and Fellow Training Committee for our challenges in the fundamentals of endoscopic surgery exam. We've got a fantastic panel tonight. I'd like to say this is our first collaboration with the Association for Residency Administrators in Surgery. We're very excited to provide content to a very diverse audience. I'd like to talk about the benefits of being a SAGES member. We'd like to go over the SAGES core values right now, which are service, innovation, global community, excellence, and inclusiveness. And I think when you see the Board of Governors there, I know our speakers are on the Board of Governors as well. As you see, really an amazing collaborative family. And just briefly talking about our speakers for tonight, I think Jason Olaski is going to start us off. She's on the Board of Governors for a commitment with the Fundamental Use of Surgical Energy program, and is going to talk about the fundamentals of laparoscopic surgery drills. I see got Sarah Hennessy from UT Southwestern with a fantastic program with Dan Scott, past president of SAGES. See Jim Ellsbeer's on with loop reduction, which is a fantastic talk, and he's the recent award recipient of the Ponsky Master Educator Award. Congratulations, Dr. Ellsbeer. And we've also have from just up the street, Lauren McLean, University of New Mexico. I'd like to thank my speakers so much for coming tonight. What we're going to do is have everyone complete their talks and then have a group roundtable discussion at the end. Anybody like to add to the introduction so far? Dr. Jason Olaski, welcome.
Thank you. Thank you to SAGES and Brianne and Brian for having me here to talk. Let me share my screen. Can everyone hear me okay first? Yeah, okay, great. All right, so we'll do this. And then let's just make that slideshow. Okay, does that look pretty good? Okay, so I'm Jason Olaski. I'm a surgeon at Mount Auburn Hospital in Cambridge, which is a PIDMC and Harvard Med School affiliate. And as Brian mentioned, I'm on the co-chair of the FUSE committee, and I'm also on the FLS committee. And so I have the pleasure of introducing you a little bit to FLS. I think probably everyone here is somewhat familiar with FLS, but just in case you're not, or if you're not exactly sure why it was designed or what it's for, I thought I'd start with some objectives. These are not all of the FLS objectives, but these are the ones that I thought were specifically relevant to the skills that I'll be reviewing tonight. So one of the objectives is to set minimum standards for basic cognitive and technical skills that are used in performing laparoscopic procedures. So again, it's basic technical skills. That's why we want everyone to have achieved FLS proficiency before they finish their residency or before they sit for their boards. And that's why the exam is not trying to trick you. So I'll go through some little tips and tricks and things to know about some of the skills that I'll be talking about, but we're not trying to be overly complicated with any of this. Other objectives are to create an objective quantifiable measure to assess knowledge, judgment, and manual skills. Again, we'll be focusing on the skills tonight. And to make available to hospitals and institutions a validated tool to measure knowledge and skills that are fundamental to the performance of laparoscopic surgery. And I think that this has been accomplished pretty well. There's places all over the country and internationally where you can go to practice and to accomplish the FLS exam. So these are the FLS skills, and my talk is going to be focused on the first three that you see there: the peg transfer, pattern cutting, and the tasks. And as well as, the pattern cutting task and the ligating loop. So I'm just going to jump right in, and if I'm just trying to open my chat in case anyone has anything that they want to. I know we have the panel at the end, but I will just keep a little bit of an eye on the chat in case there's anything that the other panelists think I should emphasize as I'm going. So first, just thinking about training as you're setting out to train yourself, or if you're a residency coordinator and you're trying to think about how to train your residents. So we can look at how it's recommended to train. Oops, sorry, there we go. So the first thing is the videos that are online. It's recommended that you watch these videos several times first before you start on any of the skills. And it's also good to watch them a little bit later on. Sometimes once you've tried them, there might be things in the videos that you pick up on that you didn't notice before. The other recommendations are to train 1 hour once a day for several days a week. This is the amount that's ideal in terms of minimizing fatigue. I can speak to this from personal experience when I was a fellow. The program that I was a fellow at feels very strongly that their fellows are able to compete at the annual Top Gun competition at the SAGES meeting. And it's a very strong tradition in that fellowship. And so I can tell you that if you try, it's specific to intracorporeal suturing and knot tying. And if you start training for more than an hour or more than, let's say, 3 or 4 days a week, you really do start to get fatigue. And at some point you're maxing out and just not even improving. So try to plan your training, and training duration will vary. You should train for proficiency, and I'll go through some goals for that. But for complete novices, for FLS, we generally think that it's an average of 10 hours of practice to achieve proficiency. So this has also been studied. There was this publication is actually from 2022, and it was looking at residents who 100% of them passed the technical skills portion. And so prospectively, they were surveyed, or they were enrolled prospectively. They were surveyed after about how much time they spent. And there was an average of 6.7 hours that they spent viewing online modules over an average of 3.6 non-consecutive days. So again, they weren't trying to do a marathon and do all of this at once. And they averaged about 2.1 hours of practice on each of the 5 tasks, which is very much in line with the 10 hours that I mentioned on the slide before. And 22 out of 31 rated the ligating loop the easiest, which is one of the skills I'll cover. 13 out of 31 said precision cut was the most difficult, which I will also be covering. And I would completely agree with that from personal experience as well. And again, they had 100% pass rate. There was also another paper, which it wasn't published in a peer review journal, so I didn't include this one, but just if you're thinking about ways to stick with the training program, or ways, if you're a coordinator, to encourage your residents, there was a program in, I believe it was Louisiana, that did like a March Madness type of thing, where they actually gamified it within their own residency. So, and it was like you were, serially excluded from moving forward in the competition. And it was longitudinal over, a month or so. So it wasn't to try to, again, force people to suddenly practice nonstop. And it was doable within them being on their clinical rotations. And the residents really reported that they had a lot of fun with that. So there are some creative ways, if you're a coordinator or if you're a resident yourself, you and your friends could get together and do this and just have like a nice little, reward, or, that you could get for winning, and you would just space it out so that everyone's on each task, and, the top 5 people move forward and that kind of thing. So that could be really fun. So moving into some details on this. So we can start with the task 1. So this is PEG transfer. And so PEG transfer, first, I'm just going to go through the actual steps. You can read what's on the slide, but essentially you have a little board that has pegs on it. And first thing with all of these is that feel free to adjust the camera before you start. You want to make sure that whatever you're working on is the center, and you can make sure that your camera is straight. The objects are going to start on the same side as, someone has a hand raised, sorry. Okay, let me look. Or if whoever has their hand raised you can take yourself off mute and just feel free to ask the question. Or do I need to do something for that to work? Okay, I'm not totally sure. Are the panelists able to just take themselves off mute? If not, then just write your question in the chat and I'll keep my eye out for it. So in terms of, oh,
sorry, if questions go into the chat, I'll make sure that we can pull them and we can ask them as we go, so you don't have to try to multitask.
thank you. Okay, excellent. Then I'm actually going to close that. All right, good. So you start with the pegs, the little pegs on the pegboard on the non-dominant hand. So my right hand is my dominant hand, so they'd all be on the left. I'm going to adjust the camera, and then I'm going to be using 2 Maryland instruments usually, and I'll grasp each object with my non-dominant hand, transfer midair to the dominant, and then place on the other side. It doesn't matter which color you pick. You'll notice the pegs have different colors. It doesn't matter the order or which peg goes to which. They don't have to like match up or anything. Once they're all on that side, so in my case, it'd be left to right, then I'm going to just repeat that and transfer them all back again with that midair transfer. If I drop a peg as I'm doing that, there's no penalty for dropping it as long as it's still within the field of view and I can retrieve it. Of course, there is sort of an underlying penalty because it is timed. And so it's going to take longer to move them all back and forth if I drop them, but it's not actually a penalty error as long as I can retrieve it. If it goes outside of the field where I can't retrieve it, then there's a penalty for that because I won't be able to use that one. But I do need to continue with the remaining objects, and the drop cannot function as a transfer. So you have to remember which way you were going if you drop it, and make sure you pick it back up with the same instrument that you dropped it. The time for this begins when you touch the first object, the first peg, and it ends when you release the last one. And so that's just sort of the general instructions. So when we get into this a little bit, you can see in the picture, my first tip is just how to hold the peg with the Maryland. So this is not a peg, but hopefully you can all see this. So some people, I've proctored a lot of people in the skills lab, and some people will just like do this. And you can definitely hold a peg that way, but it's going to be a lot less efficient than if you do what's on the screen, where you actually use the hole with your Maryland to hold the side. And 2 Marylands together will fit really well in there for the transfer. It's a very secure way of transferring. So I think that's my first tip, is that whenever I see someone holding the side of it, I immediately say, switch to this way. It might take you a minute to get used to it, but it's definitely the way to do it. And then the second tip is, some of this comes naturally, but it's good to start forcing yourself to do this from a timing standpoint, which is that you start looking for the next one while you're putting one peg down. So if I'm, again, right-handed, I'm going to start lifting it up with my left hand. I'm going to transfer it to my right hand. As I'm putting it down, you'll notice that kind of when you touch the peg that it goes on, it'll sort of start to slide down on its own. So you don't necessarily have to be watching it the whole way. So as you start putting that one down, I recommend starting to think already with your other hand about picking the next one up. And that's just for efficiency. And, you don't have to focus on that at the beginning. But I think most people, once they've gotten their time to where they would definitely pass the exam, start realizing that they're doing that somewhat automatically, but you can sort of force yourself to do it. And the maximum time limit is 300 seconds to complete it all together before you would run out of time. Last thing on peg transfer in terms of training goals. So you should practice this until you can perform it in 48 seconds. So again, you have 300 for the actual total amount of time you're allowed. But if you want to have a very high chance of passing the test, get to the point where you can do it in 48 seconds without dropping any objects outside the field of view. I would encourage you to practice it until you're not really dropping anything. And then once you get to that, then you should do that on at least 2 consecutive repetitions and at least 10 more times later on. So maybe after you do it twice in a row in under 48 seconds, go on and practice something else or come back the next day. And just overall, you would have done it 12 times the way that you want before you go and take the test. So the next slide, I'm going to continue on this format. I have 3 slides for each of my 3 skills. So we can go on to number 2. So peg transfer, by the way, the one I just talked about, is a nice warm-up in general for any kind of laparoscopic skills. So no matter what you're planning to practice in the skills lab or on your home trainer, you might start with peg transfer just to warm up your hand-eye coordination. So that's a nice one that's, not too hard, not too simple either, to just always warm up with. So task 2 is the one that everyone agrees is very challenging, especially for novices. It's a little bit complicated for how you actually put the thing in the clip. If you're at a skills lab, then obviously the skills lab coordinators can help you with this. But essentially, there's the jumbo clip, you have the pattern up. The training gauze has 2 circles so that you can practice making sure that you're cutting between the 2 circles. But the actual one for the exam just says 1 circle. And if you cut inside or outside that line, you have a penalty. And so it's not better to err on the side of outside or inside. They're equally penalized. So you really want to try to stay right on that ink line. Now, when you set this up, you're going to have the jumbo clip holding one side, and the other side, I'll show you a picture in a second, is going to be held in place with these alligator clips that go on the front of the trainer. And those you can tighten down. You want to make it pretty tight. I mean, those are basically acting like your assistant surgeon. And, it is a hard task, but it's there for a reason. So what we're doing is sort of pretending that we're having to do something where you need tension. And so your assistant is holding tension, and that's the alligator clips. But then your Maryland dissector in one hand is also holding tension. And that's really the most important instrument in this, is that Maryland dissector to hold tension for you. The scissors are just cutting, and they can only cut where your Maryland allows you to hold tension. You do have to get to the circle. Sometimes people don't know what way is best. I don't think it really matters that much, but you do have to just cut into the gauze, not on the circle, to get there. And so that's not a penalty. So you cut through, you will notice the gauze is 2-ply. The pattern is only on the top, and that's the only one that counts. So practice it both ways. I definitely know some people like just doing the top one. I think that was my preference, if I remember back, but other people will cut through both layers. Again, penalty for being inside or outside. Timing begins when the gauze is first touched, and it ends when the circle is completely cut out. And so this is a picture of it. So these alligators, so that's the big jumbo clip. Those alligator clips are holding some nice tension. Now it's possible that during the task, it'll come out of these clips by accident. If you're pulling too much with the Maryland, that might happen. You're not allowed to put it back in the clips. So if that happens, then it is more of a challenge, and you'll need to just use your Maryland for all of your tension. But also remember that you are allowed to switch hands of the instruments at any time. So, I mean, for the most part, if you have a strong dominant hand, that's the one that you'd rather have the scissor in. But you don't have to continuously cut. You could go a little bit that way and then a little bit that way. So practice these different things before, and then that way you'll start to figure out what works the best for you. You have 300 seconds maximum for this one as well. And then in terms of our goals, you want to practice this until you're performing it in under 98 seconds with all the cuts again on the practice gauze made between the 2 lines. If you wanted to practice exactly the way the exam would be, then just cut right on the line. And you should do this at least twice in a row, but you definitely don't need to do it more than 80 times. 80 times is a lot. I don't know that people do it 80 times, but if you hit 80, then you've definitely practiced enough. So my last one is the ligating loop. This was the one that was listed as being the easiest in the study I mentioned before. It is to a certain extent straightforward, but there are some tricks in terms of being able to do as much as possible with one hand. And this is a really good practical one. There are times for people who end up doing hernia repairs where you might be doing a laparoscopic hernia repair and you might have an opening in your peritoneum. Sometimes it can be really nice to just lift that up with a Maryland and put a ligating loop around it so that you're not worried about, having an opening the bowel could get through or having exposed mesh. So I've used them in the OR for that purpose. And when I'm doing that, you don't have a lot of extra trocars with a TEP. So that might be a time when it's really nice to be able to just use one hand on the loop. And so this is good practice for that. So you'll adjust the camera to show the foam and a little bit below it. You'll have a grasper in one hand, and this can be a Maryland or you can use a locking grasper. And most people do prefer the locking grasper because you don't have to actually hold that instrument in your hand outside the trainer the whole time. And so if it's locking, you can let it go for a second and it'll help hold the tension on the foam without you holding it. There's a mark on the foam and you're going to position the ligating loop around it. On the outside of the plastic, there's a perforated spot you break off. And then this is the part that's a little tricky to do with one hand, but it's good to learn how. And you basically just maneuver that tight. And then there's penalties on this if it's an air knot, which just means that you cut it or stopped before you had pulled it all the way tight, or if you're off the mark. And I'll show you on the tips one way to avoid that. Timing begins when either instrument or the loop material is visible on the monitor before you touch anything even. And it ends when you've cut the end of the material inside the trainer. So going on to how this looks, there's the mark. Here they've brought in the loop and they have a ratcheted or locking grasper so that they don't necessarily have to keep a hand on this instrument the whole time because gravity will just help pull it. One tip I would recommend is right here is the edge of that plastic knot pusher, and this is true in the OR as well. Usually you want to hold that really close to your target. And if you do that, then as you tighten it down, it's going to keep the knot right there in the right spot. And that works pretty quickly. And you have 180 seconds for this. And our goals for this, you should practice it until you can do it in 53 seconds or less with up to 1 millimeter accuracy error. I think it's hard to see 1 millimeter. Just try to get it on the line, on the mark. And this is the same thing as the last one. It's achieved on 2 consecutive repetitions. And if you've done more than 80, you should definitely stop. And, really, I think once you get the hang of it, this is definitely one of the easier tasks to pass in the FLS exam. And so that's everything I have for my talk. I'm just going to take a peek at the chat. I don't see anything. And I'll be on at the end for questions with the rest of the panel if anyone has questions later.
So I'm happy to go next. We'll continue the FLS topics here. I'm Laura McLean. I'm at the University of New Mexico, and I'm going to go ahead and share my screen. I'm going to be talking about laparoscopic suturing. I hope everybody can see my screen here. Laparoscopic suturing is tasks 4 and 5. Jasa, thank you so much for going through all of the objectives and everything of FLS. I'm going to kind of focus primarily on the suturing itself and gear this talk to specifically those 2 tasks. First of all, there's been a lot of data about FLS and how we now have to pass FLS as trainees in order to become board certified. So does laparoscopic suturing simulation actually translate into the OR? And this was a study that was done by Drs. Scott and Korndorfer back in 2004. They used laparoscopic suturing simulation. They took 9 residents and that practiced on the simulator for 8 weeks during 1-hour weekly sessions. And they saw improvement in their pre and post-test scores in completion time, as well as in errors, as well as in their overall score when they compared a laparoscopic suturing on a porcine Nissen model before training and then after training. So it does really help quite a lot. I'll kind of go from there. This is the training score sheet that SAGES has available for every single one of the tasks. You can go online and see that each task has equipment listed, the timing, when it starts, when it stops, and the proficiency level listed for each of the tasks. This is extracorporeal knot task and intracorporeal knot task. And you can see there, they list, and this is from an update from 2014. There's also an update from 2019, but the 2014 update does state that proficiency is 2 minutes and 16 seconds for extracorporeal knot tying and 1 minute and 52 seconds for intracorporeal knot tying. People think that the intracorporeal knot tying is tough, but I will tell you that the amount of times that I do extracorporeal knot tying is very rare. And in residency training, I think I did it maybe once, other than doing FLS. So I would say that this is something you need to practice specifically for the test. This is a peek into the future. Extracorporeal knot tying may be eliminated from the FLS test in the future, but currently it is part of the test. So it's one of the tasks that needs to be completed for the exam. You can see here on the right side for this training score sheet, it lists, is the knot secure? Is the slit in the drain closed? How many millimeters away is the suture from the dots? And was the drain avulsed from the foam blocks? That's because those are all assessed as penalties. Again, you need to set up your ergonomics for you specifically. This is from a paper on the left, looking at proper ergonomics for laparoscopy. The laparoscopic trainers for FLS are set up so that you do have some of these ergonomics already standard for you. However, you may need to move the laparoscopic training box up on the table, or you may need to support it with a box, or you may need to stand on a step to be at the appropriate height for the laparoscopic trainer. Also, you can adjust the height of your monitor to appropriately be below your eye level. You can see condition B on the right side is at eye level, which is not ergonomic or comfortable. Lastly, on the right, you'll see the position of the ports is sort of set up standard, but when you're thinking about laparoscopic suturing, you need to be cautious and cognizant of your triangulation, where right and left work ports are versus where your camera and where your target organ are. So this is from the didactics from FLS, which the didactics are very good. A lot of it is videos to watch prior to doing all of the tasks. As Jasa had stated, it is encouraged to watch all of these videos prior to training on the skills tasks themselves. The videos go through step by step of how to suture laparoscopically. And you can see here, they talk about it step by step of how to appropriately suture in the abdomen and also during the skills test. Here, if you're more of a words person, is the description of each task and also how to complete each task and how to appropriately set up the task. There's a foam block that needs to be set up inside the trainer. There's a piece of Velcro that is marked. The Velcro on the foam block, you can see here, goes in landscape, not in portrait mode per se. And the penrose is placed in the middle of the Velcro. You need to make sure that your camera is centered on the foam block. Try not to keep it, have the camera looking too far up or below. This will help you with your task. If you also notice on here, it tells you each step because some of these aren't necessarily exactly the standard, like what we do in the operating room exactly. There's multiple ways to skin a cat. So, it's for instance, you'll see when using the suture, both the suture ends must be cut at the end of the task. And so you need to make sure that you're cutting both of them. That can be done through the same trocar or through the alternate trocar. But you do need to cut both ends of the suture. And then on task 5, it also goes through some of the very specific steps of the suturing. Specifically, you should start with a surgeon's knot or double throw, followed by 2 single throws. So it's 3 knots actually that you're tying for the completion of the FLS task 5. The maximum time limit for extracorporeal knot tying is 420 seconds, while intracorporeal knot tying is 600 seconds. With extracorporeal knot tying, you'll see that you can either use 2 needle drivers or a Maryland and a needle driver. Intracorporeal, you should choose 2 needle drivers. The suture for extracorporeal knot tying should be kept long, so either 90 centimeters or 120 centimeters in length, while the one for intracorporeal knot tying should be cut short to approximately 15 centimeters or 6 inches. Here are some of the tools that we use for the skills task 4 and 5. These should be provided and should be in working order by the testing center. You should have 2 needle drivers. You will note that some needle drivers are right left hand specific, being that the so this one specifically, the red one is right hand, the blue one is left hand, and that's because the tips actually curve slightly to the middle. The needle drivers are not allowed to be self-writing needle drivers for the test, so that is something that's specific to FLS. Additionally, you need a pair of scissors, laparoscopic scissors, and a knot pusher. The knot pusher can be a closed knot pusher or an open. The closed ones mean that you have to actually thread the knot pusher over the end of the suture, while an open one is able to be manipulated to the knot and placed at the knot, either up or down or maneuvered throughout the task. Here you can see I cut a silk suture to 15 centimeters, but you'll also need a 90 or 120 centimeter length for the test. And I think what is actually provided is 100 centimeters for the test. And then the foam block with the penrose with the slit cut at it and 2 marks for the entrance and exit points. This is just kind of how you introduce a needle into the field. The dominant hand is usually what introduces the needle. You can do it with the non-dominant hand, doesn't matter. But you should grasp the suture approximately 2 to 3 centimeters away from the needle. That's the safest and most efficient way to introduce the needle into the abdomen. Over here on the right, you'll see just some short videos of actual laparoscopic suturing to show you guys that this is exactly what we do in the OR as well. Loading the needle should be done using the non-dominant hand to stabilize the needle, and then the dominant hand grasps the needle at approximately 45-degree angle with the tip pointed towards the tip. So if you can imagine, the tip of this needle driver is pointed medially as well as the tip of the needle. Now laparoscopically, sometimes we need to turn this around and sew upside down, which you can see on the right hand side, but you'll still see that the needle is pointed with the tip of the needle driver towards the tip of the needle. The next step is actually taking the first bite. This can be done in 2 bites, like as you see here, one side of the penrose and then the second side of the penrose. It's really important to use your dominant hand to stabilize the penrose to avoid avulsing the penrose from the Velcro. And then you'll see also, once I go to pull the suture through the penrose, I again stabilize the penrose. And this is a really good way to do that with an open needle driver, so that the suture is sliding in between the tines of the needle driver. One of the principles for laparoscopic surgery, as you all well know, is that the tail should be kept very short so that you can see the tip of the tail in your limited view laparoscopically. The next step, alternately, you can take the bite in one, so going in the entry dot and out the exit dot across to the other side. It really doesn't matter. I don't think it's any less efficient to take it in 2. It's just what's kind of what you believe is safer. You can see in the real life demonstration, we took the bite in one and had no problem going across to the other side where we wanted to. So for the test, you just need to make sure that you hit the black dots. So whichever is easier for you to hit the black dots, do that one. The next portion of this is actually tying laparoscopically. So I'll hit kind of pause on this video for just a sec. What you should do is to, once you take the bite from your dominant side to your non-dominant side, you then pass the needle back to your dominant side and hold the suture with the dominant hand just beyond the needle. Additionally, if you need more length, you can hold the needle itself, but for the skills task, your suture should be long enough that you can hold the suture itself. But still you need to stay pretty close to the needle to give yourself adequate length to make the double wrapped surgeon's knot. The surgeon's knot, you can see here, is done by placing the needle drivers tip to tip and then taking the non-dominant hand along the shaft of the right dominant hand and under and then over the stitch. So if I'll kind of go back, I know a lot of you have done this before, but just briefly. So you see, I use the dominant hand to wrap the needle, wrap the suture around the non-dominant hand, and then grasp the very tip of the tail using the non-dominant hand. The suture is then pulled over the needle driver and secured in place. This creates a tight and secure first throw. So if your first throw is loose, then it may set you up for an air knot. The next step is to pass the needle to the opposite hand to then create another C. You can see the suture is in a C shape. Again, wrap the suture around the needle driver, grasping the end of the suture and pulling through until it's tight. Again, the suture is passed to the opposite hand, now back to the dominant hand and wrapped again. So at the end of these 3 throws, both suture ends are held up to be set up for cutting. And you'll see the same thing happen here laparoscopically in the OR. The needles pass back and forth to create the C shape in order to sew laparoscopically and secure the knot down. Now, you will see that on the intraoperative video, I do grasp the needle itself, and that's because I had sort of a shorter stitch, and so this is sort of a tip to be able to get more length on the stitch to be able to throw the knot with less difficulty. And I'm also using a Maryland in the laparoscopic video while I use 2 needle drivers in the task trainer video. That's just kind of a personal preference thing. I already had a Maryland in, and so getting an additional needle driver is easy enough, but another step to be had. But the benefit of needle drivers are they grasp the needle and the suture more securely than a Maryland does. And additionally, they don't have as big of divots on the side of the shaft of the needle driver that can get caught. The suture doesn't get caught as easily in those divots. So I do recommend using 2 needle drivers for the skills task. Next, you'll see what is not allowed, no pun intended, for the test. You cannot pass the suture back over using the same hand. So you'll see here, I don't switch hands for the needle. That's not allowed for the test. This is something we do in the operating room, and it makes a secure knot as long as you pass the suture and create a square knot by wrapping in 2 opposite directions, but it's not allowed for the test. You have to pass the needle back and forth. Extracorporeal knot tying, I demonstrated this without using a actually what's going on inside and outside of the abdomen, presumably. But the premise is the suture is thrown the exact same way, except for you don't allow the tail of the suture to come through the trocar. You leave it outside of the abdomen. And then once the needle is passed through the penrose, it's pulled out the trocar, and you tie your knot outside of the trocar. So you're outside of the abdomen and you're tying an open knot. And whether you want to do that as a one-hand tie or a two-hand tie, it's up to you, but you need to make a square knot. And this is done additionally in 3 ties. So you make your throw, and then you use the knot pusher to push down. Now, it is quite easy to avulse the penrose while you're pushing the knot, so you have to be very careful to and keep the suture ends very straight to be able to slide the knot down. When you're doing extracorporeal knot tying, you don't do a surgeon's knot first because it won't slide. So you do 3 knots thrown opposite ways to make a secure square knot. The next thing is cutting the suture. You're not allowed to cut just one side. So that's a no-no. You have to cut both sides for the test. So how is this scored? Well, time is definitely a component of scoring. Penalties are assessed for missing the target entry dots as well as missing the target exit, and not reapproximating the gap in the penrose or creating air knots. The most important thing is to be safe and efficient. So you're actually given quite a good length of time to complete the task. Over here on the right is actually some of the studies that FLS is based on. It's called MITSLS, which was developed in Canada for laparoscopic task training. And you can see over here on the right side, extracorporeal knot non-proficiency was given assessed at 24 points, while proficiency was assessed at 78 points. So how this score is created is taking the total time minus your completion time minus the errors times 10 and the knot security errors times 10, expert proficiency being 512, which means 88 seconds with no penalties. So proficiency should be, so you should train until you're at least at 88 seconds with no penalties. So that's all I have for today. I'm happy to take questions at the end, and thank you all for joining us.
Great. I think I'm up next, and hopefully I can share my screen without complication. Hopefully everybody can see that. I'm going to assume that's a yes.
It is in presenter view.
Okay, yeah, I was going to try to get it out of presenter view. Sorry, everybody. Not sure.
Dr. Hennessy, if you go ahead and hit the presentation, go back into the view that you were in, there should be a toggle at the top of the presenter view. So go ahead and click where your mouse is.
Oh, okay.
There you go. And then up towards the top left, it'll say, there you go.
Use slideshow?
Yep.
Okay, perfect. Is that good?
Yep.
Okay, all right. I knew that I would be the one that would have technical issues. Sorry, y'all. I'm Sarah Hennessy. I am faculty at UT Southwestern, and today I'm going to talk to you about endoscopic drills and simulation to pass fundamentals of endoscopic surgery. I have one disclosure. I'm a speaker and consultant for Boston Scientific. So I thought it was really important to start with why FES is so important. And that it's not just another certification or test that we're making the residents do just to make them, do another test. And I took this quote from this article, this editorial published by some of the greats that actually created FES and in surgical endoscopy, and can't say it any better myself. Flexible endoscopy is a central component of surgical history and is necessary for quality, comprehensive care of the surgical patient. And to give some background again as to where FES came from, how it came to be, because it is fairly new, and why it is so important, is that, within general surgery practices, both in the academic world and in community practice, endoscopy is a really core component of what we do as surgeons. In this paper with Rosen and colleagues, in 2002, 12% of their gross billings generated from only 8% of their work week came from endoscopy. In community surgical practices, endoscopy volumes account for over 50% of their cases and 43% of their total charges. And even in further studies later on, it has been shown that flexible endoscopy is the second most common procedure performed by rural surgeons. So it is really a core component of general surgery, much like laparoscopy is. And to give you all a history, 2009, the American Board of Surgery increased the number of endoscopy cases to 35 upper endoscopies and 50 lower endoscopies. And then this question came about from GI societies as to whether or not this is an adequate benchmark and does it provide for adequate training and competency in endoscopy. And when residents were surveyed in 2012, this was a single institution study. It showed that the residents that were in general surgery residency programs felt that endoscopy was relevant to their practice, but were really uncomfortable performing it. And then this was followed up with a study nationally a couple of years later that basically showed the same results. Endoscopy is important to their practice, but really not comfortable and confident performing endoscopy. 30% overall not confident in upper endoscopy, 50% not confident in lower endoscopy. So with all of these is how it came about that the American Board of Surgery with SAGES developed one, the flexible endoscopy curriculum. And so that is a well-established curriculum that you can find on the American Board of Surgery website that kind of outlines what you should be achieving at each PGY level. And then with that curriculum also comes the SAGES fundamental endoscopy surgery certification, or FES certification. And that both FEC and FES certification has to be achieved to be board eligible, so to sit for your boards. So FES was developed as a high validity, high stakes test to identify the minimum level of proficiency of the candidate. The certification as a review is two parts. One is a web-based multiple choice exam of 80 questions. And then the second part is the hands-on virtual reality platform that looks at 5 technical and psychomotor skills on the GI Mentor. You have to pass both the multiple choice exam and the skills test to pass FES. And the 5 skills tasks are each scored individually and then averaged together for your final score. So your final score is created by averaging together all 5 of them. So theoretically, you could do poorly on 1 or 2 of the skills and well on the other 3 and still pass FES. So the next few slides are really about how to prepare yourself to pass FES. This is not, I'm not going to teach you how to do endoscopy, but how to kind of plan and prepare for the exam and to be successful. So these are kind of the steps that I've outlined. Clinical experience really is essential, and I'll get into that and why in a second. To familiarize yourself with the exam. To practice in a skills training lab, if that's available to you at your institution, to ask for help. And then again, I know silly, but the clinical experience is really important. So the more you can scope, the better you will become an endoscopy and the more likely you will be to pass FES. So kind of the clinical experience part, and there might be, and you might have heard people talk about, oh, the exam, you just have to kind of be good at playing a video game to be able to pass it. And that's all it's really testing, and not really surgical endoscopy skills. And this is just not true. FES was not designed for you to master simulation. It was designed to test your core basic skills at endoscopy through these 5 tasks. It becomes a very important question, especially for those residents that may not have access to simulation-based training, is that, is this required to pass FES? And there's been a lot of studies done looking at whether or not simulation-based training is required, and it is not. There is no difference in pass rates between those residents that had simulation based training and those that did not. But there was a positive correlation between clinical lower endoscopy experience and FES skills performance, which again is why we come back to the concept and the idea that the clinical experience is really important. How much you scope, particularly lower endoscopy, becomes really critical in developing those skills that you need to master endoscopy, but also to pass FES. So what is the exam like? There is a website that you go to that I've listed here, and that kind of will go over for you both the didactic portion, also the skills portion, and how to register and sign up and what to expect. These are the 5 endoscopic skills that are tested on FES: navigation, loop reduction, retroflexion, mucosal evaluation, and targeting. And I have listed here a really good resource that I really encourage everybody to watch. If you go to SAGES TV through the SAGES website, there's a SAGES resident webinar on FES from September 2016. And the times that I've listed here, 1 hour and 10 minutes to 1 hour and 29 minutes, is where it really reviews the virtual platform and the hands-on skills test, and gives you a glimpse of what the exam will look like. I have taken these as screenshots from that webinar. Again, the FES exam, unlike the FLS exam, is really not meant for you to practice the exact skills prior to taking the exam. That is not what you will experience. So you will not be able to practice the exact tasks, how they will look, and how the feel will be. You will have abilities to practice on some things that are similar, but not exact to it. But these are actual parts of the exam, and this is on that SAGES webinar that I've taken clips from. So this is the first one, task 1, which is navigation. And I don't know if you can see, it's kind of light, but you have this kind of halo that you need to line up with this cone, and this is a 1-second hold. And you have to do this throughout this part of the task. The second one is loop reduction. This is the most challenging. I'm not going to go into it because I think that Dr. Ellesmere is going to be talking about that next. The third task is retroflexion, and you do this in with the scope retroflexed, and you have to use the probe to touch the center green area of that target with a 1-second hold. The fourth is mucosal evaluation, which you have to find the mucosal lesions and line up this kind of halo along with the mucosal finding. And then task 5 is targeting. And again, you have to, this is not in the retroflex position, unlike the other one. You have to use the probe to touch the center green and hold for 1 second. And you are timed on all these tasks, and the time will run out, whether or not you've met all the targets or seen all the mucosal lesions or have been able to reduce the loop or not. When the time is finished, the time is finished. So in terms of practice and preparation for FES, there are simulation models that are available out there. It depends on what's available to you at your institution. The ones that are most commonly used right now is the ETS Limbs and Things. A lot of people are doing animal models with pig explants. And then, of course, the computer models or the virtual reality platform, which is through GI Mentor. No matter what type of simulation you use, in simulation has been mentioned in the previous talks today with FLS, is proficiency-based training is really optimal. And you need to look for some sort of established curriculum that might be available to you at your institution or close by. So there is not a concrete curriculum that SAGES has put out or the ABS has put out. There's a lot of different opportunities. And again, simulation is not mandatory to be able to pass FES. So the principles here are really plan ahead. You can't decide to take FES and do it a week later unless you've really met all of your kind of clinical experience cases and feel comfortable. Follow a curriculum. You really have to dedicate some time, invest some energy into this. And it's really hard to just wing it, to just walk in and take the exam without having that basic clinical experience and knowing what you're getting yourself into. In terms of what's out there, I would really encourage, if you don't know, to get some experience and exposure to kind of the basic endoscopic skills, learn about the endoscopy cart, learn about the endoscope, learn how to handle the scope and the maneuvers. There's a lot that you can learn out through Dr. Google. This is a great video that Dr. Paulai has put out about introduction to flexible endoscopy. You can find it on YouTube. There's a lot of other videos on YouTube. And then, of course, you know, our favorite is going to SAGES and to the education, you know, SAGES TV, along with all the other educational opportunities there, can be quite helpful in helping you learn. The GI Mentor is a virtual reality platform that the exam is based off of. Remember, again, the cases for the FES exam are unique and not accessible, so you can't practice on them. There have been studies done looking at about how much time do you need to spend on the virtual reality platform for proficiency. Again, not a good idea to do all of this in one setting. As has been talked about with FLS, it's kind of breaking it up over several weeks, but likely, and this study demonstrated to proficiency was about 5 hours on the simulator in total. The things on GI Mentor, if you do have access to it, that I have found helpful and are included in a lot of the different curriculums out there, if you search them on studies that have been published, is Endobubble 1 and 2. You kind of learn how to pop these smiley faces with the tip of this needle, and that helps you with targeting and navigation and retroflexion. There are cases on GI Mentor and tasks that are similar to the FES exam, but are not the FES exam. These are called advanced endoscopic navigation, mucosal evaluation, retroflexion targeting, and loop reduction. There are also upper and lower GI cases on GI Mentor that you can go on and practice, and they're full cases that will help you use these tasks. This is an example of a GI Mentor curriculum that was published in surgical endoscopy in 2020 and goes through what their curriculum kind of has their residents follow in terms of the cases, the endobubble, the modules for colonoscopy and upper scope, and the amount of time it took to get to proficiency for each of those. The second model that's available is the Limbs and Things endoscopic training system. This is unlike the virtual reality platform of GI Mentor. This is an inanimate training box. It does require a scope, of course, and a tower to be able to use it, but it comes with these 2 boxes. This is for all of the 4 tasks minus loop reduction, and then this is used for loop reduction. So you can practice and get experience with all of the different FES tasks through this. This is their website on YouTube, which has a video about each of the tasks and what you need to do to be able to obtain proficiency. This is how they look like in terms of lining up the halo with a triangle, targeting and retroflexion, and not in retroflexion. And then, of course, the loop reduction and mucosal evaluation. The study that was done by Dr. Ritter, who came up with the ETS model in their group of residents, said proficiency was about 48 attempts at ETS repetitions over about 5 training sessions. So if you average each of these to be an hour, that kind of goes along with what others have found on the GI Mentor in terms of time required to become proficient and ready to take FES. Again, the most important thing is to not do all of these in one setting and to split them up. Fourth, I think the most important thing is to really ask your surgical endoscopy faculty for help. If your resources are limited, remember that you have GI faculty likely where you're training, and they're a great resource and often very happy to teach. They have a lot of experience, and so really ask your faculty for tips and tricks. If you're struggling, ask them during cases. Ask them to come to the sim lab and really help you if you're having a challenging time in terms of how to hold the scope or how to navigate. There are things that you can do during the while you're scoping to help you achieve the view or target if you're really struggling with that. And so having somebody watch you, how you hold the scope, how your body posture is, to give you tips on how to be more successful is really important. Again, and then to go back, and I don't want to harp on this too much, but I think it's really important, is that FES is not designed for you to beat the test. It's designed for you to get good, flexible endoscopy experience and to do cases. So I would really encourage you to complete your clinical endoscopy experience prior to taking FES. Do your 50 colonoscopies and 35 upper scopes. And remember that the number of lower endoscopy cases that you've done really correlates with passing FES. And that endoscopy simulation experience is not mandatory, nor is it necessary to pass FES. And this was really outlined very well by Dr. Ritter, again, who asked these 4 important questions, looking at all of the residents that have taken FES over the last several years. And what it's really shown is that was there a relationship between time spent on SIM and FES skills test score? It was really plus or minus, not really, but more likely in loop reduction and retroflexion. Is simulation-based training required to pass the exam? No. And that clinical endoscopy, especially colonoscopy, was the most important in being able to prepare and pass for FES. We published this in 2020. Of the 2,000 residents, a little more than had taken FES, 83% passed on the first try. And really what we found was the more prior cases and experience they had, the higher the pass rate. 77% of those passed with 0 to 24 prior lower endoscopy cases. And of course, those with over 200, the pass rate was 97%. Takeaways: practice, study for endoscopy, not for the FES certification. And then just an important reminder, if you do fail the FES exam, the first retest you can do, you have to wait 30 days from the initial test date, the second one, 6 months, and then the third one, 6 months. So really important to plan because you have to pass FES to be board eligible in your chief year. Thank you very much, and happy to answer questions during the panel session.
Great. I'm Jim Ellesmere, and I've been set up really nicely by Sarah as far as my topic, which is endoscopic loop reduction as the linchpin of fundamentals of endoscopic surgery. Okay, disclosures. I'll just bounce back. No biggie. Now, endoscopic loop reduction is really the focus, and I love the way Sarah said that. The focus is really about endoscopy training and not really training for an exam or necessarily, training on the simulator, but it's really about being proficient as an endoscopist. And I've had an endoscopy fellow now for about 15 years. And one of the things that I always try to get across to those fellows is that the really most important thing is in the mastery of endoscopy is scope positioning, and how to put the scope exactly where you want it and yaw, pitch, roll. But very close to that is understanding the need for loop reduction, and that is, it's kind of fundamental to scope position is knowing what loops are and how to manage them. And a lot of those concepts are really challenging. And I just go back to my own learning curve. And I went through my surgical residency, fellowship. It was even in practice probably for a little while before I really started to understand it. And so it's not an easy thing to figure out. And yet, over the last 15 years, as in my faculty life, I've come to appreciate a few things that I kind of wish I knew early on, and I'm kind of trying to impart that this evening. One of the things, and I'll say it a few times, is just practicing loop creation and reduction in a non-clinical setting, just with a colonoscope on a table with a friend is if you took away one thing from this evening as a way to get better at loop reduction, that would be one. But there's a few other pearls in there, so we'll stay tuned. The other thing that was touched on before and is amazing as far as endoscopy education today that didn't exist when I trained was the video resources that are out there. And these are three that are really pertinent to the discussion tonight, which is about loop reduction. There's a video called Basic Endoscopy Skills Training that's put out by the Canadian Association of General Surgeons that a lot of what I'm going to talk about tonight is in there, but it's an excellent video. It's about 12 minutes. I highly recommend it for anyone who's learning how to perform colonoscopy. There's another video that's I think it's the biggest fundamental change in endoscopy education in the last decade is captured in the skills enhancement for endoscopy. It's by the Canadian Association of Gastroenterology, but it really breaks open the whole idea of being consciously aware of what you're doing when you're performing colonoscopy, and it really deconstructs it and goes into great detail about how to torque the scope to provide safe colonoscopy. So it's about 30 minutes, and I would recommend that video highly. And lastly, there's a video Olympus Medical puts out, Basics of Colonoscopy. It's like a 4 set video that is excellent. It's just available on YouTube. So those are my three recommendations. I wish I had those available to me when I was learning how to do an endoscopy. Now, my personal experience with the FES exam. I took it about 10 years ago. I was on the Flex Ed committee, and we were encouraged to take the exam. At that point, I'd been practicing surgical endoscopist for about 5 years. And personally, I thought I did quite well on the written exam. And as far as the hands-on modules go, I thought I aced it really, with the exception of the loop reduction. I thought it was really challenging, and I was actually concerned that I was going to fail my FES, despite where I was in my practice. But I passed. So and Sarah highlighted today that probably my loop reduction got ironed out in the averaging process. But I'm glad I've been asked to focus on this specific issue, because I did find it challenging, and again, I've probably learned a few things along the way. Now, I did come across this. If you Google Stanford FES preparation tips, this is what they have for their recommendations for their skills lab, and I thought it was really concise and really to the point. So if I was a resident and I was just focusing on the exam, and I wasn't thinking about like how am I going to be a better endoscopist, the next two slides I'd pay attention. And basically, Brian Davis did an excellent webinar, and it was referred to earlier in 2016, Fundamentals of Endoscopic Surgery, Passing the Exam. And what I liked about this, they even put the timestamp right in there, you know, what you want to look at. And they said if you have, you know, a Symbionics, and they do in their skills lab, and we have one in our skills lab as well. And I would concur that, you know, doing these tasks, because they're 1 through 7, they're the closest ones to the ones that are on the actual exam. And they had recommended you read the FES online study material to prepare for the written portion. And that's really that if we've done a good job on that material, it should prepare you for the exam. But lastly, I think this was a good point, and it says practice some of the colonoscopy modules to practice the de-looping, since this task is on the FES, but it's not part of the fundamental skills. And I think if I had done that, I might have been less challenged when I did the actual FES. So that's it from the FES point of view. But what I really wanted to talk tonight about was really understanding loops, why they happen, and why it's important to minimize them when you're actually performing colonoscopy. And then kind of flip gears a little bit and not talk about loops too much, but really talk about strategies for advancing a colonoscope without minimizing loop formation. I think, you know, when I started on, I was really concerned about loops. When I was a trainee, I was like, how do these loops are always so perplexing? You know, how do I reduce it? And I always wanted to figure out how to reduce a loop. But really, what you figure out with time is it's not about loop reduction. It's about advancing the colonoscope. And so I'm going to focus a lot on how you advance a colonoscope safely. And then at the end, I'll touch on how do you, if the loop does form, and they do form, they form all the time, how do you get rid of it? And loops form is just the nature of colonoscopy. My trainees always make fun of me because I always try to reduce things to simple physical models. I'm an engineer, and originally before pursuing medical training, and it's hard to change that mindset. But you know, there's a physical concept of pushing a wet noodle, and that's really applicable. There's to, you know, performing colonoscopy. You got this floppy instrument and a floppy organ that's fixed in the rectum, the ascending and descending colon, and loops are going to form. That's what's going to happen if just by the very nature of the physics of that problem. And the best way to kind of understand that, and I'll go back to this concept again, is just take that colonoscope. You don't need a simulator. What you need is a table and a willing assistant to kind of provide a little bit of resistance to the end of your colonoscope. And you can easily put an alpha loop in, a reverse alpha loop, and just feel what it is to use a little torque to reduce that, pull it back, and just feel what a loop feels like when you pull it back. And I was 5 years into clinical practice before I made this observation. So it's I wish I knew it as a trainee. Loops form during colonoscopy. It's normal. You kind of go up and into the sigmoid. Sigmoid kind of courses anteriorly. And if you just go around that and don't do anything else, you're going to get a loop. You can see on the left there is what they call the end loop or a spiral loop. And then if it kind of crosses over and it looks like the Greek alpha, that's an alpha loop. And then if you keep going up around your sigmoid and up your splenic flexure, you can see in the transverse colon, you start forming a loop in your transverse colon. And those are the common ones. And then there's less common ones, and things like reverse alpha and a gamma, and some complicated splenic flexure loops. And when I put these up here to think that there was a time when I thought it was really important to identify all these by name and have a strategy to reduce all these. But the reality is that's not the way expert colonoscopists deal with loops. They just basically do one or two simple things every time, and they apply to all these loops. And I'll save those concepts to the end, because that's the thunder, I guess. I want to build up to it a little bit. But so why is managing loops important? And really, it's because it just, as I alluded to earlier, it's hard to position your scope. It's hard to get it where you want to go. Loops are forming clinically because the most common thing from a clinician's point of view is they get this paradoxical movement. They're pushing their hand, they're advancing the scope, but the actual tip's not going forward. You're putting the energy into the loop. You're not putting the energy into advancing the scope. You can also feel torque and resistance in the scope. So that's why it's important to to have a sense of how much torque's in the scope at all times. You start finding loops. Not only do they form inside where you can't see, but if you start seeing them form outside, the patient going back into the actual imager, those are oftentimes associated with loops on the inside as well. And again, from a clinical point of view, the patient starts showing discomfort. They can physiological tachy response or even a vagal response of bradycardia and verbal complaints. So all these things are your clues clinically that loops are occurring, and the reason why you want to deal with the loops. So let's start and just talk about all the things that really are key to advancing the scope, because that's the concept. It's really about, how do I advance the scope easily? And if you can do that, then all of a sudden the scope's in the cecum and you didn't form a loop. So let's break it down. Lubrication. Thought I knew everything about lubrication when I was a resident, but turns out, I was pretty good at putting the muco on the scope and the anal canal. But what I've come to appreciate over the last decade is that it's really important to put copious amounts of irrigation in the actual colon for a couple different reasons, but specifically around lubrication. The colon can be very dry. Some people are very dry. It can be dehydrated after the bowel preps. And so you almost have to, add fluid as per what you find, but the mucus that lines the colon itself can be made much more slippery with adding fluid. And it also helps with the actual lubricant that you put on. And really the goal of a well lubricated colon is to have really minimal drag on a colonoscope. And it's funny, you say, well, that doesn't seem like a big deal, but you learn, when you're teaching people how to do colonoscopy, somebody's stuck and you don't know why, and you're trying to help them, and you realize that this scope is got tons of drag on the colonoscope. So they didn't either put enough lube in, or they didn't put enough irrigation. The other concept that's really important is a very subtle little thing it's challenging for trainees to appreciate, is oftentimes when you're doing colonoscopy, you're moving your scope back and forth, and that's really almost assessing that drag component. But when you're trying to accordion that bowel onto your scope, moving the scope back and forth, very subtle little technique. Learners don't like to do it. They just want to go forward. They don't want to come back. But again, a little subtle thing that really helps you and assess that drag, but also move that scope along as you go to the cecum. I don't want to spend a lot of time talking about torque versus tip steering. That Canadian Association of Gastroenterology video is excellent as far as really deconstructing this. But it's important to mention a few concepts. One thing is the right hand that you grasp the shaft of the colonoscope with. When I was a resident, I was certainly taught to grab it with a fist, but all the kind of new thinking on endoscopy is you're just holding it with your fingers. It makes it a lot easier to kind of detect resistance in the scope, and actually makes it easier to put rotation into the shaft between your finger and your thumb. And it's a subtle little advantage, but it's a powerful technique to appreciate. Torque can also be introduced by rotating the scope, but also rotating the patient. That's not something that's often intuitive. I know when I was training, it was always about just turning the scope. But the idea is if you rotate the patient, you're also every time you rotate the patient, you're introducing 90 degrees of torque. And so that's relative to the scope. So that's another important concept. Why are you torquing? You're torquing to see part of the lumen. When you're doing colonoscopy, you don't want to go around the blind turns. You want to do things that enables you to see the lumen so you can safely pass that scope to the cecum. Those resistance points, if you don't, sometimes become places where you form loops. That's how it ties into the loop. And again, that tip steering as a concept should be minimized. Now, patient positioning. Again, something that I have learned a lot about in the last decade, and it's something that was really well established by the radiologists who used to do all the barium enemas and the other GI contrast studies. The idea of how do you move the fluid out of the way, put the air to see the lumen, and it's exactly the same concept when you're doing colonoscopy for optimal visualization, but it also is important for scope advancement as well. There's that idea that you can use gravity really to flatten out turns, particularly flexures. And that's important because some of the challenging things when you're learning is how to get around the splenic flexure. How do I get around the hepatic flexure? Well, if I can just position the patient so that all of a sudden is not so acute, all of a sudden that really becomes a real way to kind of, again, not get stuck up and forming a loop. And I'll talk about that. I'll deconstruct that a little bit on a segment by segment basis. And then there's the last point I've already brought up, which is providing additional torque by rotating the patient around the scope. So there's all these concepts that are tied into patient positioning that we're only appreciating, more so now as far as endoscopy education that we certainly didn't when I was training. So there's this concept of the ideal position actually depends on the segment of valve. So I think we're all pretty comfortable with the idea that you go in the rectum and sigmoid, the patient's in the left lateral, so left side down is kind of standard. And then I would say most people that in practice would maybe run around the whole colon on the left lateral, run into some problems, they may switch over to supine. And that may be fine. Again, there's actually data out there that would show that if you actually rotate the position for the ideal segment all the way around, it actually improves your adeno detection rate in randomized trials. But what's more important from the ideal position is that when you run into problems at these areas, if you actually know the ideal position for every one of these regions, before you kind of get challenged and frustrated, if you can just put them in what's the ideal position, you'd be surprised how much it helps you to advance the scope without kind of running into resistance. And so in the splenic flexure, it's actually right lateral as opposed to left lateral is the ideal. And it's that idea that you're hanging the splenic flexure from the, and it flattens it out. Transverse colon, it's supine. Hepatic flexure, same thing, it's left lateral. And then as you come down into the cecum, it's supine or even right lateral, because that'll help you actually appreciate. If you're having a hard time seeing around the IC valve, you put them in the right lateral position. And again, it's the same kind of thing. You're hanging it in the air. It's all just like those radiologists were doing for years. They don't do anymore because, CT colonography has replaced it. But pressure, I learned a lot about pressure when I was in trainee, like how to do pressure. Interestingly enough, it's largely been replaced by repositioning. In fact, some of the people that are all the big advocates for repositioning say you should never use pressure. It's inappropriate. I think they're going too far. There's definitely a role for helping get across a big loop in the transverse colon. And if you have somebody who knows what they're doing, they can provide very good lower abdominal pressure for difficult sigmoid loops as well. One important concept I remember in my training was that if you're asking somebody to help you find the scope, find the loop, put a little pressure on, don't move your tip at the same time. Just wait until because they're actually looking at the tip themselves. They're trying to see if their pressure is having an impact on the tip. And if it does, then you can go ahead and then, advance your scope at this point. But it's really hard if you're flipping your tip around when they're trying to apply pressure. Prone positioning is another way to provide pressure. It's not used very often, but if you flip them prone, that is a way to put generalized pressure on the abdomen. It can help under some circumstances. And lastly, something that's been more used recently is this idea of taking big breaths for your patient, and probably you as well. A yoga moment is never a bad idea. But for the patient, if they take a big breath, flatten their diaphragms, that can actually help, again, navigate some difficult splenic and hepatic flexures. Insufflation. Well, there's all these concepts about colonic advancement, but even thinking about, I used a lot of air, and now air is almost passe. It's all about water, minimal air, put a whole bunch of water. We talked about the reason for do it for lubrication, but even beyond that, if you put a whole bunch of water in the sigmoid colon, you weigh that colon down, you prevent lengthening, and that prevents loop formation. There's that prevent loop formation concept. Air insufflation is really, it's the opposite. If you put a whole bunch of air in there, you get a big distended colon. It's very, very challenging. It's very easy to make loops, and then it's very challenging with those loops to get to the cecum. Suctioning, suctioning is a huge part of success when it comes to therapeutic endoscopy. But it's specifically as far as colonic advancement, it's an important concept. The idea is you make your colon smaller and then you minimize the length of scope that's needed to pass each of those segments. Very effective for cording your scope on. It's important concept. Stiffeners, some scopes have stiffeners. The idea is you want a flexible scope to get through the sigmoid. And then once you get through the sigmoid and you have your scope straight and you put that stiffener on, and it can help you get to the cecum. It's not as effective as all those other strategies we talked about. It's a nice feature on your scope, but and it does help, but it's all those other concepts are actually way more powerful as far as getting to the cecum in a timely fashion. Okay, here we go. I was asked to talk about loop reduction. And so, and again, this is where I approached it early on. It's like, well, there must be a way to do loop reduction. It's really about how to do colonic advancement, colonoscopic advancement. And this is how you do loop reduction. You don't need to know the name of every loop. If a loop forms, we talked about how you know that's forming. You kind of hook it around your scope, around a turn or a flexure, and then you provide a little torque, whether that's clockwise or counterclockwise. Usually what most of us will do, we'll try clockwise. If that doesn't work, we'll try counterclockwise. And then once you do reduce that loop, keep that torque in, and then to advance that scope again. Those Olympus videos show that beautifully. So if you want to see that concept, check out those Olympus videos that I showed earlier. And the other important concept is loop reduction is not always possible. When I was a trainee, I was under the impression that you can always reduce every loop. That's not the case. There's always a situation where you're going to be in the long position, and you just need to understand that periodically. But it's not something you want to be in it, because it is associated with poor outcomes. Poor cecal intubation, poor adenoma detection rate, and higher complication rate. So it's not something you want to embrace as a practice, but it's every once in a while it happens. So in summary, looping is an oral part of colonoscopy. It is a challenge. The linchpin of FES, I guess, would be I agree with the description. Loops can be minimized by using proper scope advancement technique. That's a take-home message. When they do form, hook a turn or flexure, torque the scope and reduce. And then the last thing here is, try to mock this up. Have a table, have a colonoscope, put some alpha loops in, put a beta loop in. It's not hard to do. Just start pushing a scope against something, you'll form a loop. Then feel what it is to kind of torque that loop out and pull it back. It's a great exercise, and it'll provide you with a lot of insight and clarity on how to manage loops. That's thank you.
I love that picture of you and your family in Nova Scotia, Jim. That's fantastic.
Yeah, that's it's me and my girls up in Cape Breton, an island there in the north part of Nova Scotia.
That's gorgeous. I'd like to thank everybody for staying with us, and thanks to Dr. Ellesmere for talking about our 2016 webinar. SAGES is always about really providing great service for residents and for trainees to really get passionate about innovation, improving your skills technique. And I actually learned quite a bit from Dr. Ellesmere's talk about torque and all these positional ideas that are really changing the way we think about endoscopy. I'd like to also mention that we have a survey coming up at the end of this presentation within 5 minutes, so that we can get your opinion on how we can improve webinars. I'd like to encourage everyone to join SAGES as a candidate member. And then for those of us that are going to be at Surgical Education Week, we'll be very happy to actually meet our counterparts in the Association for Residency Administrators in Surgery in San Antonio coming up soon. I think it's great that we start going through some of these questions in the chat that are so critical. And as you may have noticed, we have quite a diversity of women experts, people from the Board of Governors, simulation experts, to answer our probably number one question, which is why there's this training differential in endoscopy between men and women. Who'd like to start?
I could start. So if, and I didn't explain the entire slide that I had with the article, and I can, as I'm talking, I can share it for those that are interested in seeing it, but there is a difference in FES exam outcomes between men and women. Can you guys all see that? The pass rate for women is 72%, and the pass rate for men is 91%. So that is a substantial difference, and it's a real difference. And this has been shown through several studies that have been done looking at the FES exam and the passing rates and characteristics of those residents that are passing and not over the last several years. There is, obviously, we don't exactly know why this is. I think that as a female endoscopist, my thoughts are a few on it. I do think that the handle on the endoscope is larger than my hand, and it takes a little bit of time. You know, you can train your hand, and what I tell our female residents that almost uniformly ask me, they say, I feel like my hand's not big enough, that I can't hold the scope and maneuver the dials with one hand, and then hold the other end. And I say, your hand's going to hurt. It's going to feel like it's stretching beyond its abilities, but you do learn over time how to hold that scope and able to move the dials with smaller hands. I've had female residents that have glove sizes that are down to 5.5, and it is challenging for them. And I think having a female endoscopist, if that's available to them, whether it's a surgical endoscopist or a gastroenterologist that's a female, kind of show them some tips and tricks of things you can do, locking the wheels. If you're in a really tight spot, sometimes I know it's not great, but I'll actually bring the scope handle to the end of the scope if I really need both my hands and I just can't make it stretch or enough. But there are some maneuvers and techniques. But I tell all the residents, your hands are just going to hurt for a while. And that is what it is, I think. And then you learn. And then I think the pass rate is some of that. And some of it may be the way either we teach women versus men in endoscopy or training, surgical training as a whole. Maybe this is outlining some bigger differential and the experience or training that men versus women receive in general surgery residency. Maybe it has to do with a difference in how women perceive their abilities going into the exam versus men. I think, it's going to be hard to figure all of that out, but there is an obvious difference. And I petitioned to have scopes made for women. If it'll happen or not, we'll see.
Have we considered as a SAGES committee group whether or not we should allow women just to compete with women and men just to compete with men? And I'm not talking about swimming, but endoscopy.
Dr. Ellesmere has so much more experience in FES and Flex Center than I have. I've not heard of us having any conversation or discussion about that in the FES committee, but I don't know if you have.
Well, as you know, it's it's complicated when you start changing issues. I think this came out, it was a couple of years ago, and I think there was a number of possibilities that were raised as to what made, and it could be hand size. Correct me if I'm wrong. I thought there was some correlate. Some of the preliminary data around hand size didn't correlate with.
Yeah, that's true. And then in that study that we did in 2020, there was not a correlation with hand size, although there aren't that many men that have very small hands. So
right. Yeah, no, that's fair. Yeah.
But there was no correlation with hand size.
Yeah. So so there's, I think it's, my sense from the FES committee work is that it's an area of ongoing investigation. There hasn't been an interest in kind of separating, like redoing all the scores for women and then redoing all the scores for men. That idea hasn't been proposed. I think there would be advantages of that. I think there'd also be disadvantages of that. So I think that the strategy of continuing to explore the issues is really important in trying to provide some clarity as to what is the root cause. But like that's where the committee is at this particular point. But I don't speak for the committee per se. But that was my observation.
I also don't speak for the committee, but would think that I'm not as familiar with the data, I think, as others on this panel for this topic in particular. However, the benchmarks for, I mean, it's basically training for proficiency. So you'd have to have experts go through that same study, not trainees. And you would have to establish if there's an issue in experts first. But because I wonder, you know, again, if it's something to do with how we're training people and what their volume of experiences and things like that, or volume is, you know, how many you logged. That doesn't necessarily mean how many you actually did or did enough to learn from. So there may be some other issues we probably don't have time to talk about on this panel. But it is interesting. I was just thinking the same thing Sarah said about sometimes I do that little cheat move where I kind of bring the controls over to where my other hand is directing things. And I do more upper scopes than lower, so I don't run into as much trouble, I think, just because you don't have as many corners to navigate and what have you.
Yeah, and I totally agree with that. And obviously, there's no difference between female endoscopists that are established, you know, that are full and male endoscopists and outcomes. So obviously, at some point, it goes away. The difference goes away, and so it may really have to do with the way we're training, or the experience, or the case volume.
I would have to agree. I'm not on the FES committee, but I do a lot of upper endoscopy. I don't do much lower endoscopy. And I think just as a personal sort of anecdote is that I had to figure out my own way to do endoscopy. You know, training with people gave me tips and tricks of how they did it, but there wasn't any one specific person that did it exactly how I do it now. And I think that's with anything in surgery. And so maybe it is that at the time that our trainees are taking FES, they haven't quite figured out how they need to do endoscopy to achieve the goal at hand. And some of it is maybe coming up with those little tips of taking your, you know, your hand that's controlling the wheels to the other hand. Mine, a lot of times, is moving my body, my whole body to move the scope, which, you know, I was taught some, but actually I didn't really learn that until like fellowship, that I really needed to use my body during endoscopy. And part of that was, I think I didn't have enough grip strength with my right hand. And so using my body enables me to have more grip strength with my right hand to give more torque to the scope. And so I think learning those little tips and tricks is something that you may be able to achieve from a female endoscopist teacher, or maybe just somebody your own size, or maybe somebody who is left-handed if you're left-handed. Similarly, I think similarly with laparoscopy, we forget a lot of times that people are left-handed. And so we make a lot of videos that are right-hand dominant, but I actually switched all the videos from left hand to right hand. And so, so if you're doing these things left-handed, you won't see videos out there from left-handed doing these tasks left-handed, left-hand dominant. So those kinds of things you may not learn in residency, and you may need to extrapolate to your own skill level or your own specialties.
I think this provides some fascinating training gaps. I'm going to bring this up to Jim Ellesmere because, Jim, you're really, you know, part of the high leadership for the Flexible Endoscopy Committee. It also has to bring in, you know, Brianne Nickel. Would you all consider there's a high value for SAGES providing instructional videos for tips and tricks for women, specifically to meet this training gap?
I think there would be. I mean, I have a large residency program, and we're at a 50-50 split now between men and women, and we have our residents complete endoscopy as a part, or FES as like sort of like the capstone end of their endoscopy rotation. And I always have several of the female residents that'll say, I'm not ready to do it yet, it's not going to work. I always, you know, the simulator, but and they always say it's their hands. And so we We did do what Dr. Hennessy suggested. We brought in one of our female, our new hires, female colorectal surgeons. We have 2 female colorectal or fellows this year we brought up to sort of work with them. And I think it is a matter of the more you do it, the more comfortable you get with it. But I think anything to show them, just like, a left-handed person, like showing somebody with smaller hands, how to hold on to I lost the term that Dr. Hennessy used, the thing that does all the things would be very helpful. As my English degree is really strong here today.
Yeah, I would, it's interesting how a lot of those things I talk about, positioning and just the feeling of holding the scope with your fingers as opposed to, it's a lot of it. It's actually, a lot of those techniques are kind of less manipulating your hands and more just those fine little touches. So it's a lot of it in some ways it's once you start using those fingertip techniques, it's a lot less kind of dependent on hand as well. So some of that is just, I think there's an opportunity to disseminate that colonoscopy education best practice that's still out there. And I think once we have a broader adoption of best practice, you'll see that it's actually better for people with smaller hands, basically, as a concept, basically.
I
There
agree.
are questions in the chat.
Oh, sure. And then I think it's also, as Dr. Ellesmere said, it's, the novice, like just gripping the scope because, you're new at it and you're gripping it really hard and you're not using your fingertips as much. And so I think that makes a big difference, but we can go to the other questions.
Well, Dr. Hennessy, one of your mentors brought up a really great point. It was Danny Scott, brought up the same problem at Southwestern. And he said, what happens is in the GI group, the GI pushes the scope and the resident runs the knobs. And he found out after a lot of feedback, people were failing the exam because they didn't have what Dr. Ellesmere is talking about, which is the fingertip torque. And it's really interesting because if they're training surgeons that way, are they also training their own trainees that way? So even people that think they're master educators may not be understanding the importance of teaching torque as a fundamental component, which is why I bring up this whole concept of a training gap with Sage's videos that we say, hey, we're not just training women how to pass, but we're looking at these fundamental master educator techniques that even somebody like Danny Scott at Southwestern goes, wow, this is huge in the overall realization of how people are not passing that exam.
Yeah.
Yeah, I agree. I think there's an education gap there that we continue to work on as a community.
So somebody brought up, what about colonoscopy in the case of sinus inversus? Has anyone ever seen that or had that? It's a fascinating question.
Yeah, no, I've definitely seen sinus inversus, and I've definitely done endoscopy on cases with sinus inversus. A lot about the if you take that patient positioning and think of it from a principal's point of view, you can realize that instead of going left lateral to start off with, you're going to go right lateral, and you just kind of flip the sides, and it would be applicable to from an ideal patient positioning point of view as you go around. And if you don't do that with the sinus inversus, it's actually going to be very challenging as far as patient positioning, because it's not about being ideal patient position. You're going to have, in many cases, very non-ideal, which is okay. I mean, the reality is you can do endoscopy in a non-ideal patient position. We do it all the time. Oftentimes, positioning is a compromise, particularly if, for example, patients that just need general anesthetics for whatever reasons. It's a common thing, therapeutics, ERCP, and even every once in a while colonoscopy. And patient positioning, when you have somebody who's on a general anesthetic, is limited. And so there's an example where you just can't take advantage of that. So you could do a sinus inversus and prone if you had to, but it's not something I would say it's ideal, but yeah, it's just, you can do colonoscopy in someone with sinus inversions, no question about it.
So I hate to ignore fundamentals of laparoscopic surgery. Dr. Olasky and Dr. McLean, I heard a lot about fundamentals of laparoscopic surgery 2.0. Would you like to kind of go into a little bit of detail on how that's changing, please?
I'm not sure exactly which of the changes are formalized publicly. However, there's been a re-review of all the questions. So that's been a major endeavor. It's almost done. So I've been able to be a part of that project, which has been a really cool experience. And essentially, we have experts, third-party experts who talk with us about how the questions do. We make sure in a rigorous process that the questions are applicable to everyone taking the exam, no matter what field you're in. We make sure that they're fair and also come up with some new ones. So that, I think it's been almost 10 years or so since the original, so just about 10. So it's really good to have this process. So that's a big part of it. I know there are also some smaller changes to the skills exam that will be released soon as well.
I heard a rumor there would be significant changes to the laparoscopic suturing requirement. Is that true?
Well, one of the changes that is in the works is actually removing the extracorporeal knot tying portion. There's not a defined date of when that will be removed, but that is most likely going to happen. So that's to be determined. So that will most likely happen within the next year or two. And then beyond that, like Dr. Olasky said, there's a whole new question bank version that's going to be beta tested, I think, starting in early 2023, maybe late 2022. And that also goes along with the addition of adding, so now, I don't know if you guys know, but all of the OBGYN residents are required by ACOG to pass the fundamentals of laparoscopic surgery exam. And so making the test applicable to them and their specialties, and taking out a lot of the question data that is procedure specific and making it more task specific. So that's another portion of the test that's being revitalized. And the skills is, going to be completely reimagined. So we're kind of taking it from even almost a blank page and trying to reimagine what the future of taking a skills test would be like, whether that's a more virtual test environment, or if it remains a hands-on practical portion. But I will tell you that a year or two ago, no, 2 years ago now, there was a survey that went out to all SAGES members to identify the portions of laparoscopic surgery, basic laparoscopic surgery skills, and what everybody thinks is important. And so some of those things correlated with the current skills, and some of them didn't. So for instance, one of the major things that people want tested is trocar insertion, which is currently not a skill that's tested. And so there's a lot that goes along with identifying what those tasks are. And like Dr. Olasky said, we have some third-party educator and test and curriculum experts that are helping to advise and make our test the most reliable indicator of what basic laparoscopic skills are in 2022 and not 1986. But yeah, I think it's exciting to be a part of making a whole new test, but the trainees should be comfortable in what it is right now. There's not going to be any like big changes before you take the test. And those changes will roll out slowly over time. And the appropriate didactics will be updated, et cetera, before those changes are being made. Oh, another thing is just to let you guys know, currently FLS, because of COVID, sort of the test split. And so you no longer have to take the written portion at the same time that you take the skills portion of the test. You do have to pass the written portion before you pass the skills portion of the test. But the test, it has gone to like virtual proctors and then virtual proctor in a box for skills evaluation. And that has allowed the committee to understand that virtual proctoring is possible and is part of the future. And so a lot of those things that we learned through COVID are going to extend into the future of test taking, which I think a lot of people are really happy about.
Thank you so much for that update. I think one of the most interesting questions is, what do we do about motion sickness in the simulator, right, Brian Nickel?
Yeah, I saw that. I've got a couple of residents that get motion sickness, and I get motion sick in the car, but I never thought about getting motion sick with virtual reality. But then I got to try the robot out a couple weeks ago and thought I was going to die afterwards. So it's a real thing. What I have in my office, I have a couple pair of C-bands. Some of the residents swear by them. Some of the residents say it didn't help. Whether it's all in their head or not is not for me to determine. I also have tiny, they're quiet white noise stands that sit by the simulators that they can turn on so it doesn't disturb anybody else, but it'll blow cold air on them, which helps. We always have snacks. We keep water over there for them to grab. We've got a bench that they can sit in, and then we just really encourage them to like put a timer on their phone when they're practicing and like take a break every 15 to 20 minutes. And if they get motion sick, like from the get-go, I kind of tell them to just like do it in increments, like try it, do it for 5 minutes and then take a break. And then the next time do it for 6 and just sort of build it up. And those sort of strategies have seemed to help my residents.
Fantastic feedback. So we're continuing with this collaboration with ARAS. And I think in September, we're going to have a career development webinar as well. What else can we do, Brianne Nickel, to help your coordinator group with content?
That's a good question. I mean, I think this is a really good start. I know I learned some things about the FES portion of credentialing that I wasn't even aware of, despite the fact that I sometimes feel like I have half the SAGES committee living in my office. I will say that I think robotics seems to be the next sort of black box for us in terms of understanding it, where it's going, what we're doing with it. So we'll definitely take any sort of education that you have on that. And then also, I think some of our sites, some of our administrators, it's nice to hear Dr. McLean talk about how virtual proctoring might be a thing, so that maybe residents don't always have to travel to certain sites, like they can set it up at their own institution. One of the institutions that don't have proctors at their sites, when residents fail the test the first time, whether it's FLS or FES, they don't always know how to help troubleshoot and sort of assist where the errors are. And so I think anything that can sort of help administrators that are also proctors, or even residents sort of understand, okay, I didn't pass the first time, kind of like, how do we move forward? What do we need to focus on? How can we get it so that we pass it the next time? I think will be the next sort of thing that would help us the most, for sure.
Fantastic feedback. Thank you. So at last, we're hitting 7 o'clock. I know everybody's exhausted. Thanks so much to Jim Ellesmere and Sarah Hennessy from my hometown of Dallas, of course, Jason Boston, and Lauren McLean, just north of me in Albuquerque. So become a SAGES member. It's a huge family. There are incredible opportunities to collaborate, be in leadership, and change the way we educate surgeons. And I'll also say, come to Surgical Education Week, my home state, one of the best cities in the country, San Antonio. Will have a blast. Thanks everybody for all your time and enthusiasm. It's great to see everyone.
Thank
Good
you.
night.
Night, everybody.